Hi everyone, this is Andrea. We are going to go through Chapter 9, Nursing Care of Patients in Shock. Objectives for this chapter are going to be found on the first page of the chapter, as well as remember referring back to the course guide for Nursing Care of Adults 1 that's on Brightspace that has objectives as well. So those are great ways to help review for your exam to make sure that you can answer all of the objectives. Shock is a life-threatening medical emergency. If somebody's in shock, it's very important as nurses that we take very critical steps to help save these clients' lives. Shock is inadequate tissue perfusion. Okay, inadequate tissue perfusion. It's insufficient delivery of oxygen and nutrients to body tissues. And that inadequate delivery happens because there's inadequate perfusion, and there's inadequate removal of waste products, and an imbalance between oxygen supply and demand. So it's a very critical state. On the third bullet where it says inadequate removal of waste products, what we see primarily is a decrease in urine output. So for our clients that are in shock, even though they're given IV fluids in early stages, they still will have very decreased urine output. And remembering back to your renal units, usually we like to see at least 30 milliliters of urine an hour. That's kind of our bare minimum. So we should hopefully be seeing more than that. If we see less than that, we'd be very concerned. These patients overall are in a state of circulatory collapse. If they don't have immediate treatment, organ damage and death can occur. The pathophysiology of shock gets back to tissue perfusion. So we have to maintain perfusion to our tissues throughout our entire body. And the way that we do that is through three different ways. The first is having adequate blood volume, so adequate circulating blood volume. The second is effective cardiac pump, so having a heart that works correctly. And the third is having effective blood vessels. Okay, so if we think about that in simple terms, we have to have enough blood in our body, we have to have a heart that works, and we have to have blood vessels that can carry the blood around our body. If we don't have that, no matter what we do to try to get out of these shock type of states, it may not be successful. So for example, someone goes into shock, but they have heart failure and they have valves that aren't working, or they have low blood volume. Unless we can correct those things, we may not be able to get them out of a shocky state. And for somebody that has a bad heart, that's an older adult, likely that outcome can be very severe. When these body systems fail, our body tries to compensate. Okay, when these body systems fail, our body tries to compensate. And what happens a lot of times, unfortunately, is our blood pressure drops even lower. So our blood pressure drops even lower, which leads to even worse tissue perfusion and worse outcomes. So as nurses, I want you to think about if you see a client coming in with a really low blood pressure, you always need to be thinking in the back of your mind shock. Honestly, really low blood pressures, systolically, less than 100, if their baseline is 120s, systolic numbers are a little bit more significant to us, but systolic numbers in the 80s, 70s, 60s, those are really, really, really severe. And those should scare you even more than your blood pressures that run in systolically the 150s or above. So those low blood pressures can definitely be a very big concern. Common causes of shock are inadequate cardiac output. So someone that has heart failure, and that gets back to our last slide. Remember, they don't have an effective cardiac pump. Sudden loss of blood volume or hemorrhage, that gets back to having adequate blood volume. Sudden decrease in peripheral vascular resistance, anaphylaxis, an infection that has spread into the bloodstream, sepsis, or neurologic alterations. And we'll talk about these in a lot more detail, but just kind of getting back to any shocky state is going to result in those low blood pressure readings. Metabolic and hemodynamic changes that you'll see in your clients with shock, they will have changes to their sympathetic nervous system, okay? Their sympathetic nervous system. This will result in tachycardia, so a very fast heart rate, tachypnea, fast respirations, oliguria, decreased urine output, and we'll also see cool, clammy skin, often with pallor. That's illustrated here in the client on the screen, but really important, cool, clammy skin. You're not going to be able to assess that unless you actually touch your patient. So when you're doing your assessment, it's so important that you not just only look and listen, you have to feel, or you'll miss some of those early signs. Cool, clammy skin, we might also worry about someone that is diabetic, that has a low blood sugar. So you have to rule out those things in these situations. So you take that blood sugar, make sure it's okay, and if it is okay, then your mind starts going maybe down the potential shock path. Again, decreased blood pressure. When the sympathetic nervous system is activated, epinephrine and norepinephrine are released, and that's what causes our heart to beat faster and stronger. It's that fight or flight reflex. The blood in this case will get shunted to our brain, our liver, and our heart. So sympathetic nervous system is the nervous system that if we're walking in the woods and all of a sudden a big grizzly bear comes out from behind a tree, we would instantly get into that fight or flight mode, and we would start to run. We would either fight or flight. Usually we'd probably run. And to do that, our heart's going to start beating faster. We're going to start breathing faster, and our blood is going to go to those essential organs. So the same thing's happening when we talk about shock. In your book, there's a really helpful table, 9.1. Mean arterial pressure, also called MAP, tells us how well organs are being perfused. So when we talk about perfusion, that's a key component of shock. Normal MAP is 70 to 110. MAP, arterial pressure, is created by a calculation off of blood pressure. In order to have a MAP where we know that the coronary arteries are actually getting perfused, that number needs to be greater than 60. So for nurses that are working, especially in the ICU setting, they pay a lot more attention to the MAP than they do the blood pressure, because it will tell them if the coronary arteries are being perfused. So an example, if we look at this screen, we see the red numbers there are the blood pressure values. So 121 over 82 is the blood pressure, and the MAP, or the mean arterial pressure, is 98, which is a good MAP. We said normal is 70 to 110. We want that number to definitely be greater than 60. So when you're back out in the clinical setting, you can start looking at those numbers now when you experiment with that electronic technology. Very helpful. Effect on organs. Tissue ischemia and organ injury. Kidney, liver, immune system, and the heart are all impacted. And brain death can occur if there is lack of oxygen for over 4 minutes. Okay, so if somebody's blood pressure gets so low and they're not getting perfusion to the brain, if that happens for more than 4 minutes, it can actually cause brain death. Okay, so tissue ischemia and organ injury, kidney, liver, immune system, and the heart are impacted. Brain death can occur if there's lack of oxygen for over 4 minutes. Some additional information you notice on your screen, lactic acid is mentioned in the lower corner. So when cells in our body are deprived of oxygen, they start switching from what's called aerobic metabolism, which is metabolism that requires oxygen, to anaerobic metabolism, which is a process that does not require oxygen. The byproduct when our body switches to that anaerobic metabolism is lactic acid. So in these clients that are in a shocky state, we're going to see a buildup of lactic acid, usually in the body. Lactic acid causes more acidic levels in the bloodstream. So acidosis, pH below 7.35, is also a classic sign of shock. Okay. In addition, when other effects on our organs, specifically the kidneys, blood gets shunted away from the kidneys early in shock to save fluid and provide oxygen to vital organs. Blood gets shunted away from the kidneys in early shock to save fluid and provide oxygen to vital organs. Kidneys can tolerate this reduced blood flow for about an hour. Okay, they can do that for about an hour. Otherwise, if that continues, then we can have cell death in the kidneys as well. When this happens, the BUN and the creatinine levels are going to elevate. So another thing we might see, so we could see these patients' ABGs would be acidic. We could see increased lactic acid in their labs. We could also see a high BUN, high creatinine. Liver damage that occurs will also cause abnormal clotting and elevation in liver enzymes. So their AST and ALT levels will be elevated. The immune system gets depleted of white blood cells, so these clients are at an increased risk for infection. The heart has an increased need to beat faster with less oxygen available. Okay, it beats faster with less oxygen available, so we get decreased cardiac output. This can definitely cause dysrhythmias, myocardial ischemia, or myocardial infarctions. So really kind of realizing that this effect is systemic. It affects the organs throughout the entire body in very specific ways. Complications from shock, acute respiratory distress syndrome or ARDS, disseminal intravascular coagulation or DIC, and multiple organ dysfunction syndrome or MODS. ARDS is a type of respiratory failure. It typically requires very high levels of supplemental oxygen and mechanical ventilation. I do have a link in Brightspace that has a very good visual explanation of ARDS that I'd like you to look at for additional information in addition to your textbook. DIC results from ischemic damage to the epithelial lining of blood vessels. It causes formation of tiny thrombi or blood clots and depletion of tissue clotting factors at the same time. So when someone has DIC, they are almost clotting and bleeding at the same time. So they're throwing these tiny little thrombi, but they're also using up clotting factors. So it's a very serious situation. We can see DIC happen as well in moms when they're delivering, but we definitely can see that happen in shock. So what are some of the things we might notice in our clients? They could have pain, redness, swelling from a clot at the same time that they have extra bleeding coming out of orifices, extra bleeding in their gums, blood in their urine, those types of things. So very serious. MODS is usually respiratory failure, followed by kidney failure, heart, liver, and finally cerebral and GI function to fail. So multiple organ dysfunction syndrome. And again, that just leads back to these organs aren't getting perfused. And if these organs aren't getting perfused and getting the nutrients and oxygen and all the supplies that they need to function, they're going to fail. Okay, typically the respiratory component fails first. And sometimes when that respiratory component fails, that can be end of life for that client because airway is the most important thing we need. Sometimes it just compromises the respiratory system, leads to a multiple organ dysfunction system failure, and then cascades from there. Now we're going to get into the specific kinds of shock. So the very first one we'll start with is hypovolemic shock. Hypovolemic shock. So this type of shock, if we just look at the word hypo, meaning low, volemic, volume of the blood, okay? So hypovolemic shock, decreased circulating blood volume. Typically, this tends to be caused by hemorrhage. That hemorrhage can happen from a trauma. So client could be in a car accident, have severe abdominal trauma causing a hemorrhage, a GI ulcer, so a stomach ulcer that's bleeding, any surgery where there's inadequate clotting, something doesn't get cauterized how it needs to, the client has hemophilia, liver disease, cancer, or anticoagulation therapy kind of in their history. There's a table 9.3 in your book that gives some more information as well. It can also be caused, another cause is dehydration. So hemorrhage, dehydration. Dehydration caused by vomiting or diarrhea. Diaphoresis, which is sweating. Diuretic therapy, so giving diuretics and without good replacement fluids can cause dehydration, which could lead to hypovolemic shock, or NG suctioning, and that's what the canister and NG line here are in your screen are illustrating. So if you have a client that has GI issues, they're vomiting, they have diarrhea, they have NG suction, think of all the volume of fluid that they're losing because of that and how that's going to decrease their circulating blood volume. So really important to think about that as well. Hypovolemic shock assessment. So if someone's in hypovolemic shock, we're going to get a very thorough history. We need to know their age, any recent illnesses, any recent traumas, what medications they're taking. Specifically, we're going to pay attention to those diuretics. Fluid intake, any bleeding, internal or external bleeding that they're aware of or that we noticed. We're going to look at their vital signs and their clinical signs. Do they look pale? Does their skin feel cool or clammy? Do they have decreased urine output? Do they have any changes to their mental status? The vital signs for these clients will typically be where their heart rate's going to be elevated because their blood volume is depleted, so the heart's trying to compensate for that. Their blood pressure is lower. Their respiratory rate is higher. Their O2 saturations are lower. And their pulse pressure is lower. So those are pretty trademark hypovolemic shock signs. You notice that blood pressure is low for these clients as well. As nurses, we really need to monitor for any unexplained tachycardia or tachypnea. Possible sources of fluid loss. So in addition to any bleeding or wounds, do we notice any vomiting, diarrhea that they're currently having or that they've had recently? Signs of inadequate tissue perfusion are apprehension, increased anxiety, agitation, and mental status changes. So when somebody doesn't have good tissue perfusion, good oxygenation, a lot of times they can get kind of agitated and have a little bit of increased anxiety. And as nurses, that needs to be kind of a cue to us to check their oxygen saturations and potentially put supplemental oxygen on them because we expect their O2 sats to drop. Lab values. So in these situations, hemoglobin and hematocrit will be obtained, usually ABGs, electrolytes, cultures if there's anything suspecting infection. We're also looking for any bruising or petechiae. If somebody has internal bleeding, then their hemoglobin and hematocrit numbers are going to be decreased. Usually when hemoglobin levels drop below 8 tends to be when clients will receive supplemental blood products or a blood transfusion. All right, and then we talked about the vitals. So that's a busy slide. Hypovolemic shock interventions. As nurses, airway is number one, so ensuring a patent airway. Making sure that our client has a large bore IV, so it needs to be one of the lower gauges, 16, 18 gauge IV, so that blood products can be infused. Typically, we look for those 18 gauges if we can achieve them. And as LPNs, you're not going to be doing that, but you could easily be taking care of a client that needs these interventions. So you're going to be working with an RN that could do that skill, but you're still going to assume care that you need to make sure that your client has that in place. Okay. Supply supplemental oxygen if needed. Put our patients in Trendelenburg position where their head is low and their feet are high, and that will promote perfusion to the brain. Check for visible bleeding. If there is any visible bleeding, making sure that we apply pressure. Checking vital signs very frequently, so at least about every 5 minutes, because they're going to change very rapidly, especially if our patient is in a severe shocky state. Increase the IV rate as ordered, and then administering blood or blood products as ordered. IV crystalloid solutions are usually given to maintain adequate fluid and electrolyte balance, and those crystalloid solutions tend to be just normal saline instead of LR. Sometimes lactated ringers are used, but if we think back to when we talked about IV fluids, normal saline would kind of be the fluid of choice because it's rehydrating. It's our best rehydrating fluid, and it's compatible with blood. So if we have that hanging, we can easily adapt that with our blood tubing and our blood products. So that's helpful. Packed red blood cells are going to help restore blood volume without adding excessive fluid volume. And then one thing I do want you to do is take a look in your Davis drug guide. Traditionally, we would do this in class, but I want you to look up dopamine. Okay, I want you to look up dopamine. I want you to look up what its action is and what are some of the side effects of dopamine. So what does it do in the body and how would that change our assessment? Okay, or what things would we look for in our assessment knowing what dopamine does? So that's kind of a little side assignment that I would have given you in class. So review question, hypovolemic shock is caused by which of the following? So take a minute to look at those answers. Okay, the answer for this is A decrease in the circulating blood volume. And specifically, we're talking here about hypovolemic shock. Next, we're going to go into cardiogenic shock. Cardiogenic shock. So some students tend to, however you organize your thoughts or your notes, but make like a separate page for each of these different types of shocks to kind of keep it all straight. You do whatever works for you, but just making sure that you kind of differentiate between the different shocks that we're going to talk about. So cardiac failure that's secondary to an MI or CHF. Signs and symptoms can be similar to hypovolemic shock. We tend to see distended jugular veins for individuals in cardiac shock. So if we look at the client here on the screen, if you notice, where his jugular vein is on the side of his neck, and you see how pronounced that is, we call that distended. So for this client, you notice that's on his right side, and all of our fluid returns back to the heart and goes into the right side of the heart first. So that's where we tend to see that backup. And if we notice that, we get concerned about potential for cardiogenic shock. These clients are going to have decreased cardiac output. If they have heart damage, they can end up with pulmonary edema. Our priority for these clients is to help restore cardiac function. If we're looking for that jugular vein distension, it tends to be more pronounced if our patient's in Fowler's position. They turn their head away from us like the gentleman's doing in the picture, and the head of the bed is about 15 to 30 degrees. Usually we can see it the best if they're in that position. Treatment for cardiogenic shock, our goal is to reestablish circulation to heart tissue and improve the heart's effectiveness as a pump while decreasing myocardial oxygen requirements. That's a mouthful, right? So let's kind of break that apart. reestablish circulation to the heart. So making sure that the heart is getting perfused. Improve how the heart pumps, and decreasing the oxygen requirement to the heart because it's pumping more effectively. Okay, so in order to do that, some of the things that are usually administered are IV morphine. This decreases pulmonary congestion, and it also helps relieve pain. Oxygen is often applied by nasal cannula or by mask if more oxygen is needed. If these clients don't have good respiratory support, sometimes they even have to be intubated. Treatment as far as medications, diuretics may be given. Fibrinolytic therapy may be given. I'll have you look up these two drugs as well, alteplase and streptokinase. So you can look up their actions and their side effects. We would typically do that in class. The dissolved clot dissolving the clot by giving these medications can help relieve the symptoms of a MI if that's happening, myocardial infarction. And then I'll also have you look up these vasopressors, so dopamine to butamine if you haven't, their action side effects. Vasopressors are going to increase the force of cardiac contraction. Fibrinolytic therapy, if those are administered, obviously not only will that dissolve the clot, but that's going to increase the risk for bleeding as well. So making sure we keep that in mind, knowing what these drugs do and what that could cause. Distributive shock is the next type of shock we're going to talk about. Distributive shock. Massive vasodilation of peripheral circulation with pooling of blood in venous and capillary beds and increased blood vessel permeability. Okay, so this is just kind of the big umbrella. Within distributive shock, we have anaphylactic shock, septic shock, and neurogenic shock. So we're going to talk about those individually, but just to kind of introduce, those all fall under types of distributive shock. Anaphylactic shock is probably the one that you're most familiar with. Extreme hypersensitivity reaction to an antigen. So with anaphylactic shock, it's important as nurses that we teach allergy avoidance methods. Most common type of anaphylactic shock is food allergies. Specifically, what we really see a lot now is peanut allergies. For individuals that have this, they have to carry an epinephrine auto injector. These are really cool. Just a little personal story on this. This is something that we have to carry for our daughter. A lot of times these talk to you now, so they're very tech savvy. Individuals should carry a medical alert bracelet or information. If somebody's having an anaphylactic shock, we're going to see urticaria or hives, laryngeal edema, which we worry about compromised airway, bronchospasms, and a lot of anxiety because these individuals feel that their airway is closing and it's getting more difficult to breathe. We also need to think about anaphylactic shock when we're talking about any medication allergies that our clients have. So say your client's allergic to penicillin, they're also usually going to react to anything that's in that penicillin family. So you have to make sure that you know the drugs that you're giving. If you're giving an antibiotic, you need to know what family it falls in. If they're allergic to sulfa or penicillin, are you giving something that's in one of those families that could also cause a reaction? When anaphylactic shock occurs, histamine is released, and this causes bronchoconstriction, mucosal edema, and additional mucus production. A lot of times when these clients develop that laryngeal edema, they feel like it's just like a lump in their throat. And what we may feel or hear in our assessment is just hoarseness in their voice, which can eventually switch to a stridor. Patients can definitely lose their airway completely and have to be intubated. In your book, there is a helpful chart for this, but medications that we give for anaphylactic shock are epinephrine and diphenhydramine, which is Benadryl. When we give these medications, secondary, what's going to happen is when we give epi, they're going to have tachycardia, tremors, nervousness, restlessness. That's expected. And when we give diphenhydramine, they can get drowsy, confused, have a dry mouth. So keeping that in mind, giving these life-saving medications, but then knowing what's the normal, what's going to happen to our clients, what do we expect to see afterwards. And also with teaching, if we have to send somebody home with an EpiPen, we need to teach them what they would feel like after they gave themselves that EpiPen so they don't get more scared when they feel like their heart starts to race. Other things that can be given are bronchodilators that are going to reduce the inflammatory response. So prednisone, Solumedrol, those types of medications could be given as well. But our first line is epinephrine and diphenhydramine. The review question, the nurse teaches patients with allergies, which of these? And the answer is B, carry an epinephrine injector. Septic shock is the next type of distributive shock that we're going to talk about. Septic shock is also one you may be a little bit more familiar with from the clinical setting. This is caused by an infection. So it's caused by bacteria. In the upper right corner of your screen, you see gram-positive bacteria versus gram-negative bacteria. For those of you that have had microbiology, you may have had the chance to look at bacteria under the microscope, but when we get our results back from lab, or you're getting a report as nurses, the nurse may share that the client has gram-positive bacteria in the blood or gram-negative bacteria in the blood. And that's just, realizing that the type of bacteria that it is going to shape what antibiotics are used to treat that bacteria. The most common types of septic shock are caused by usually gram-negative bacteria, E. coli, Pseudomonas, Klebsiella. Sometimes gram-positive bacteria, staph and strep is also common, but just realizing that those are kind of the main types of bacteria within those two different categories. Dilation of blood vessels and fluid shift to interstitial space. Okay, so the blood vessels are going to dilate and the fluid's going to shift into the cells. And this is going to deplete these clients of fluid and cause a very big drop in blood pressure. Some of the predisposing conditions to septic shock would be trauma with large open wounds, because those are prone to become infected. Diabetes, because we know that diabetes the increased sugar levels can fuel the bacteria and fuel the infections to become worse. Corticosteroid therapy puts clients at greater risk for developing infections. Anyone that's immunocompromised. Exposure to invasive procedures, which increase the risk of infection. Cancer, because we know these clients are immunocompromised. They don't have high white blood cell count numbers high enough to fight infections. They tend to be very low. And an infection with restraint microorganisms. Septic shock is the leading cause of death among intensive care patients, especially those who are age 85 and over. With these clients, they have increased white blood cells with decreased segmented mature neutrophils and an increase in bands. So what we see in this on our labs is what we call a shift to the left when we see these changes in their specific white blood cell counts. What you're going to see the most in your clients as far as lab work is you're going to see really high white blood cell counts. Those white blood cell counts should be responding to therapy. So if your client's getting IV antibiotics, those white blood cell counts should trend back down. You should definitely see a decrease in the counts within 24 hours of that first IV dose of antibiotic. If you see an increase, then we know that they're probably not on the right antibiotic. So with these clients, we really want to get a blood culture. So we want to get a culture of their blood when they start to show signs of septic shock, so that we can try to test for susceptibilities and what antibiotics are going to work better, but realize that can all be skewed if they've already been started on antibiotics for something else. So it's tricky. It's a very tricky road to walk down. Symptoms of someone in septic shock: abnormally high or low temperature, heart rate greater than 90 beats per minute, respiratory rate greater than 20 breaths per minute, white cell count less than 4,000 or greater than 12,000, that should say. And realize that with those low white blood cell counts, typically we'll see that in somebody that's immunocompromised because they just can't get those white cell count numbers up. 10% of bands, immature neutrophils. These clients are going to develop a systemic inflammatory response syndrome. And that's going to be diagnosed if 2 or more of these symptoms are present. Just a little side note, personal experience story for you, because I think that helps hit home. What you'll see the most in your practice if you're going to work in the hospital setting is sepsis or septic shock that results from sepsis. And these clients change very quickly. So they can be stable and everything can seem fine, and then within half an hour's time, everything can change. So many years ago, I had a client come up. They had just had a gallbladder removal, cholecystectomy, simple surgery. There's not a lot of complications other than risk for infection, risk for bleeding. But this client came up to the floor, and I was working charge nurse, and I was helping out the primary nurse, and we have to do surgical vitals afterwards. So we did the first set of vitals and things came back okay. Did the next set of vitals and we noticed the temperature was a little bit higher than the first time, but nothing real crazy difference. So we went okay. And then just looking at the client, you could tell they were changing. They were pale. They just looked sick. They looked different. So we didn't wait the full amount of time and took vitals again. And their temperature had increased almost 3 degrees from the time that we last took it till the next time, which was less than a half an hour worth of time. So that client was eventually shipped out of the hospital to a larger facility, was in septic shock, ended up being in the ICU for almost 14 days, made a full recovery, but just a crazy story about what can happen when someone's in these shock type of states. So, never assume that something's so simple that it can't lead to a really bad outcome. So as nurses, we need to be on high alert. We need to be taking vitals, assessing our patient, looking at our patient. If we know the baseline, we're going to know when something changes. So hopefully that helps hit home a little bit with that story. Treatment, cultures are really important for septic shock. Blood cultures will be obtained from 2 different sites. And the reason they're done from 2 different sites is just to make sure that we have a comparison in case one sample would be contaminated. Urine, blood, or sputum samples, depending on where we think the infection source is. Really important. We try to get those before our client, when we notice those temperature changes or we notice the septic shock starting. Again, like I said, sometimes they're already on antibiotics, so the culture and sensitivity results are a little skewed because of that, but we do our best. And then antibiotics are used to treat the infection. Labs that are really important to us are a CBC, a BMP, and an H&H. And anybody that's in these shocky type states, septic shock, they're going to definitely need some IV fluids to replace their fluid volume status. There is a sepsis video as well on Brightspace that just kind of helps you get another perspective about taking care of patients with sepsis. So take a look at that as well. Neurogenic shock. Again, this is the last type of shock that falls under distributive shock, neurogenic shock. This is very rare. So we're going to cover it, but I don't have a lot of extra information for it, this type of shock. This is excessive dilation of the peripheral blood vessels. So remember, peripheral, in your peripheries, your arms, legs, things away from your core, due to injury to the nervous system. These usually result, this type of shock usually results after a spinal cord injury. Other causes could be general anesthesia, fever, brain contusions and concussions. So usually when the spinal cord is involved, that's when this type of shock happens. So signs and symptoms, early signs and symptoms that this is happening is hypotension, altered mental status, bradycardia, and warm and dry skin. Late signs would be tachycardia and cool, clammy skin. So those are specific to neurogenic shock. So this finishes up our chapter 9, and that will end this recording. Thank you so much for listening.